Good morning, all of you. We warmly welcome you to Acute Respiratory Infections in Children and Updates, organized jointly by the Respiratory Study Group of Colombo South Teaching Hospital, together with the Clinical Society of Colombo Hospital. Sorry for the slight delay happened due to unavoidable technical errors. Why acute respiratory infections in children are important for us. As we all know, acute respiratory infections, we basically classify it into two, depending on the anatomical sites involved, as upper respiratory tract infection or lower respiratory tract infection. But acute respiratory infections are not always confined to the respiratory tract. They can present with systemic effects due to possible extension of the infection, possibly due to the production of microbial toxins, toxin effect, inflammatory response on top of that. When you get a respiratory infection, obviously your lung function going down. That can contribute to systemic presentation. How do we get acute respiratory infections? Children, they acquired infections either come from community, where they are playing playgrounds, school, even their homes itself are a risk factor and they can get the infections. And certain amount of acute respiratory acquired infections, children, they acquire while they come to the healthcare facilities. We have to slightly more worry about them also. They could be due to the organism, which we are not thinking in the first instances. Majority of acute respiratory infection, that means more than 90% of acute respiratory infections are due to viruses. Bacteria, fungi, parasites may also can cause acute respiratory infections in given settings. The organism or the etiologies causing acute respiratory infections has changed a lot. The main contributing factor which had changed the epidemiology of acute respiratory infections in children is successful implementation of vaccines into the childhood immunization program. Good two examples are the Hep B vaccination and pneumococcal vaccine into the in some countries to the expanded immunization program in childhood. What about the prevalence of acute respiratory infection? Is it a problem of us, we in developing countries? No. Acute respiratory infection is a challenge for the health facilities in both developed and developing countries. But unfortunately, high morbidity and mortality occurs in developing countries, especially Africa and also from the Asian continent. According to this study, it is estimated that Bangladesh, India, Indonesia together and Nepal together account for 40% of acute respiratory infection mortality. Where do we stand? There are several studies done in different parts of the country on prevalence of acute respiratory infection among children. They have found almost all the etiologies we come across in our country, and there's a difference between the etiologies depending on age of the children. And you see, we also see the seasonality in the country with acute respiratory infection. Right. Although we know majority of respiratory infections are viral in origin, we happen to start on antibiotic treatment in addition to the supportive treatment. All the children are susceptible to infections. Clinical presentation of acute respiratory infections range from mild to severe life-threatening disease. Although we can guess in some instances, clinical manifestations of acute respiratory infections rarely provides the specific etiological diagnosis. And the possible etiologies and the severity of the disease varies with age, immune status of the children, nutritional status, associated comorbidities, and living environment, and the exposure histories. How we are going to manage? We have to start on antibiotic for the children presenting with acute respiratory infections due to severity in presentation. Sorry. That's all right. So it happened us to start on antibiotic treatment for children presenting with acute respiratory illnesses due to severity of presentations, limited availability of laboratory facilities, and restricted access to the radiological investigations. However, it's our responsibility to rationalize our treatment when we see the clinical improvement, when we get the laboratory results together with the imaging finding in required cases. Over-treating and not treating appropriately both cause bad outcomes with acute respiratory infections. Completion of antibiotics for appropriate duration. This includes oral treatment, IV treatment, and appropriate switching from IV to orals. That will prevent recurrences, minimize adverse effects, mitigate emergence of antibiotic resistance, and also reduce associated morbidity and mortality. So, we doctors will make management of acute respiratory infections in the country by prompt diagnosis and appropriate management, which will prevent progression of the disease, reduce complications, prevent transmission of infection in the community as well as inside the healthcare facilities, will help to mitigate occurrence of antibiotic resistance, and also we can prevent outbreaks, epidemics, and pandemics due to respiratory infections. So we are in a best time to discuss about acute respiratory infections. Infection control and preventive actions which took place with the COVID-19 pandemic has resulted in significant decrease in acute respiratory infections among children. Are we there still? No. We are seeing significant backing of acute respiratory infections again in the country.
Actually, I thank the Colombo South Teaching Hospital Clinical Society for giving me this opportunity to speak about acute respiratory infections in children. So my topic is epidemiology of acute respiratory infections in children. I'm Dr. Samanmali Gunasekara, consultant microbiologist at Apeksha Hospital. So pneumonia is the single greatest cause of death in children worldwide, as you all know. Each year, 2 million children younger than 5 years die of pneumonia, and it's 20% of all deaths in that age group. So about 155 million cases of pneumonia occur in children worldwide. So out of them, majority of cases are from the developing countries. And the incidence and the pathogens have changed recently because of the implementation of Haemophilus influenza B vaccine and pneumococcal vaccine. Hib vaccine is there with us in the National Immunization Program, but pneumococcal vaccine is not there, but it's available in the private sector in Sri Lanka. But in other countries, Western countries and other developed world, for their children, they receive pneumococcal vaccine. And also COVID-19 pandemic altered the epidemiology of acute respiratory tract infection in children. That is because wearing of masks and less gathering, and schools were closed. And also we didn't check for other viruses. During last 2 years, we concentrated only on COVID virus. So therefore, the data is not there. Like we have missed some data on epidemiology of respiratory tract infection in children last 2 years. So it is acute respiratory infections are the main cause of morbidity also in children under 5 years. So and also in developing countries, identifying the etiology is difficult, because in children it's difficult to get samples also. No, you can't get expectorated sputum, and getting a nasopharyngeal swab is also difficult, and sometimes parents don't like us doing. And also with this virus, to diagnose viruses, we don't have many tests. So because of that, identifying the etiology is difficult. So because of that, WHO recommend making the diagnosis clinical, based on clinical parameters. But the associated mortality is reduced if you diagnose from diagnosis and timely commencement of treatment. So acute respiratory tract infection in this age group is predominantly due to viruses, and followed by bacteria. Now I told you about in 2008, there are 150 million cases of pneumonia. So majority of 151 million cases are from developing countries. So there are reasons for that. I'll come to that later. So more than 20 million children with severe disease require inpatient care annually. Incidence of in the developing countries demonstrate a rate of 15 to 21 children younger than 5 years old. So in developing countries, 15 to 21% of them are but in developed countries, incidence of pneumonia is less. It's I can't see the number here because of the panel, and it's less anyway. For 10,000, I think it's somewhere around 3. No, I can't see the figure because of the panel and window here, and it's less in developed countries. Can I move this window? Otherwise, I can't see some. Yeah. Yes, it is 33% for 10,000 children in developed countries, but in developing countries, it's 15 to 21% children. So its figures are like the numbers are very high in developing countries. So what are the risk factors associated? There are environmental related risk factors for these acute respiratory tract infections in children. The most significant risk factors are malnutrition, low birth weight children, and non-exclusive breastfeeding. And air pollution is very common now because of the industrial work, and indoor crowding. It's very common in our part of the world with population growth and poverty, though indoor crowding is a problem. And also lack of measles immunization in children less than 1 year of age. So it is not a problem for us because our immunization coverage is very good. So other important risk factors are parental smoking, zinc deficiency, and all other micronutrient deficiency, and also with other comorbid conditions like asthma, heart disease, renal disease, and liver. This is all these problems. And there are possible associated risk factors. They may include mother's education and daycare attendance. You all know that when you send your child to the daycare, they always catch something and come home and give it to the other children also at home. And humidity and cold weather, vitamin A deficiency, and also outdoor air pollution. Those are also possible associated risk factors. Etiology, respiratory etiology or the causing agent. The respiratory tract infections are caused by both viral and bacterial organisms, but in children under 5 years, viruses are more common. So also these viral infections are the main cause of mild to moderate infections. So it may be either with upper respiratory, like common cold or upper respiratory infection, or mild to moderate pneumonia. So bacterial infections are the leading cause of severe pneumonia, but this is not always. Sometimes even the viruses also can cause severe pneumonia. Other organisms like fungi and parasitic etiologies are not very common unless the patient is immunosuppressed. If your patient is immunocompromised, you have to think of other causes also. Or it could be either community acquired or hospital acquired. Then you have to think of the pathogens also different. So if it is a hospital acquired pneumonia, different pathogens. If it is a community acquired pneumonia, so there are some other pathogens involved. Viruses have been recognized as the most common cause of acute respiratory infection in young children. It accounts for 30 to 67% of pneumonia in children younger than less than 1 year. So present with mild to severe life-threatening, there are deaths also with acute respiratory infections. So outcome depends on the virulence of the pathogen and host factors like immunosuppression. If they are very young age, they are high risk, and also with other comorbid conditions, and also availability the facilities for management. If you are in a very good center, the survival is better. Otherwise, there may be fatalities. It accounts for 40 to 50% of pneumonia hospitalization among under 5-year age in developing countries. So this study, study was done to identify the viral diversity in acute respiratory tract infections. This was done in 2 hospitals in Sri Lanka, one in wet zone and one in dry zone, one in Anuradhapura and Gampola. So they have the results are like this. You can see here RSV, respiratory syncytial, or in all age groups up to 60 months or 5 years. All age groups, respiratory syncytial virus is the commonest isolate in comparison to other viruses. So, and next is adenovirus. So all age groups and adenovirus is this, and these are para-influenza viruses and influenza A, B, and human metapneumovirus. Their incidences numbers are less. So this is mainly due to because this RSV is not a seasonal virus. I mean, it's occurs throughout the year. So that is the reason why the numbers are high. But influenza and para-influenza are seasonal. Therefore, the numbers are less. But nowadays, I think we see a lot of influenza and para hospital in one ward, pediatric ward. We have randomly done 5 samples with acute respiratory tract infections in children in one pediatric ward. Out of 5, 4 were influenza B and 1 was COVID. So now there is a outbreak of influenza at the moment with the rain and cold weather. So in that study here, you can see the morbidity and mortality. Also in teaching hospital Anuradhapura, 418 children were hospitalized, and Gampola 443 were hospitalized. And out of them, around 30 to 40% of them, of the patients, they have viral diagnosis was positive. And there was number of deaths, 6 and 3 in each hospitals. And so you can see here the etiology of mortality. RSV is there all the time. RSV alone or RSV in combination with other viruses. Here two RS2 respiratory syncytial virus, and the other one is RSV plus parainfluenza 1. Another 2 with RSV and human metapneumovirus. So RSV is the culprit for deaths in all deaths in this study. So here in Gampola also 2, and then RSV and PIV parainfluenza virus for the other day. So this is something you have to think of. And other viruses which can cause severe disease, these are the viruses can cause severe disease: RSV, parainfluenza, adeno, influenza A, and rhinovirus. So something about respiratory syncytial virus. It is detected in 15 to 40% of children admitted with acute respiratory tract infection in developing countries. Remains as important fatal pathogen, sometimes in combination with other, maybe with other viruses or bacterial pathogens. So it can cause bronchiolitis in very young children. So most severe form of disease occurs in infants 3 weeks to 3 months. Very young children, severe disease and fatal disease occurs. So due to bronchiolitis. So in developing countries with temperate climate have shown similar seasonal pattern in Western countries, but in tropical countries like us, it's there throughout the year, and increased incidence in the rainy or cold weather, rainy season or cold weather. Parainfluenza virus, you get 3 types, 1, 2, and 3. They are the second leading cause of viral respiratory infections in children. They can cause CROP and also PIV3 cause bronchiolitis pneumonia in very young children, less than 12 months of age. Influenza virus, it's mainly seasonal epidemics, especially in temperate climates. You get winter peaks, but with us, we also get seasonal pattern, but still not cold weather, and sometimes even during some other months also we get epidemics like occurs as a consequence of, because this virus is very known to cause antigenic changes in the virus, change the antigen during the course of not course of illness actually, during the year they change the antigenicity. That's why we always change our vaccine also. We give one vaccine with some antigens this year, and next year we have to change the antigens in the virus vaccine because of the antigenic changes in the virus. Influenza hospitalization rates are due to severe disease. So you can see here, when young children are more prone to get severe disease, 9 per 100,000 in children less than 6 months of age. So if the young children get the disease, they are more prone to get severe disease and complications. Annual you have to, and also this vaccine we have to give annually because of this antigenic change. So for children in Sri Lanka, we don't, it's not recommended, but in other countries, it is recommended, but for in Sri Lanka, it is recommended only for immunocompromised or children with some other comorbid conditions. We recommend annual influenza vaccine, but not for other children. So, but severe fatal disease can occur in all age groups in children. The seasonality pattern of influenza is different around the world. So we get seasonal epidemic peaks in winter in temperate climate. But tropical regions can include a whole year, but it's also, we also get epidemic peaks. Adenovirus, it accounts for 2 to 5% of all respiratory infections. Even there, like you get high incidence in winter. In other regions, it occurs all over the year. Human rhinovirus, well-known cause of upper respiratory tract infection or common cold. So nearly half of the children develop lower respiratory. They can also, this virus also can cause lower respiratory tract infections. So the prevalence of rhinovirus in children shows geographical variation. It occurs year-round, so not associated with any specific season worldwide. So occurs in both dry and rainy seasons in the tropics. Then COVID-19 in children. In children, it's less likely to become, normally they are not severely ill, they get very mild symptoms, or 50% of children might have COVID-19 with no symptoms. They may be asymptomatic. But with medical conditions like asthma and heart disease, renal disease, they might increase the risk of serious illness. And also miscellaneous inflammatory syndrome in children. It's a serious condition where some organ becomes severely inflamed. It is due to the excessive immune response to the virus. So it is a antibody, like that's why we always, when we suspect MIS-C in a child, we check for antibodies. Sometimes the symptoms of COVID is not there at that time, but antibodies are positive. So due to excessive immune reaction, they get this severe inflammation. And in Sri Lanka, we recommend vaccine only for children more than 12 years. That is to prevent child from getting and spreading in the school, and also to prevent severe disease. And also they can participate in sports and other group activities if they are immunized during the pandemic period. So other viruses like metapneumo and Boca virus, they are not very common, and we don't know because we don't check for these viruses, but they are not very uncommon. We don't have facilities to test for these viruses. Even these viruses also can cause acute respiratory infections, measles, varicella, herpes simplex, CMV, and enteroviruses. What are the bacteria causing acute respiratory infection in children? So the top one is Streptococcus pneumoniae and Haemophilus influenza type B, Staphylococcus aureus, and other streptococci. And atypical pneumonia also not uncommon. So you can get mycoplasma and chlamydia pneumonia. Streptococcus pneumonia is a frequent cause of morbidity and mortality among children all over the world. So they mainly affect children under 5 years of age in developing countries, but because in developed countries, the children are vaccinated. If they are under 2 years, we vaccinate with the conjugate vaccine. Otherwise, the pneumococcal polysaccharide vaccine is there. But with us, it's not there in the national immunization program. CDC data indicate that children less than 2 years of age have most prevalence of invasive disease. So invasive disease is pneumonia and meningitis. In under 2 years, it's invasive disease is common with Streptococcus pneumoniae. Even pneumococcal infection peaks in the winter in temperate climates. So after the introduction of pneumococcal vaccine, there is a decline of the outbreak of invasive disease in children under 5 years, and also decrease of penicillin-resistant pneumococcal infection. So penicillin resistance is a big problem. Even in Sri Lanka, penicillin resistant rates are very high in pneumococci, and also sometimes you get cefotaxime resistance. Then we'll have to treat with some other high antibiotics like vancomycin, or maybe some quinolone antibiotics like moxifloxacin and levofloxacin. So it is so introduction. If after the introduction, the incidence is less in other countries. Haemophilus influenza type B is the other second important bacterial pathogen. So now it's there in our national immunization program. So prior to introduction of this Hep vaccine, so only in 200 children less than 5 years old develop invasive influenza B disease. And also it's nearly 2/3 of Hep infections occurring in children under 18 months. So the children are very young. The more higher the risk of acquiring this Haemophilus influenza type B infection. But infection still occurs in unvaccinated or incompletely vaccinated children in the world. So outbreaks have fallen 99% after vaccination. So it's a big achievement to have this vaccine in our national immunization program. Staphylococcus aureus, known to cause rapidly progressive pneumonia in children, viral infection, upper respiratory infection with influenza or COVID-19. You can get this Staphylococcus aureus infection, pneumonia, because of the severe damage due to this virus. So it's very, it's common. It's not common actually. It happens after the viral infection normally. You can get respiratory failure and severe disease. So we have limited data about MRSA, respiratory tract infection in children, but it is there, but we don't have many, data. Mycoplasma infection, it is categorized as an atypical pathogen because this mycoplasma we can't grow in our culture media in the laboratory because it's a fastidious organism, and that is, so we go by mainly the serologic testing, antibody tests, and also PCR tests also available now, but it's expensive, and it is it is the one of the most important cause of lower respiratory tract infection worldwide. But mostly we get the retrospective diagnosis with the rising titer of antibody, or may sometimes it's not available all the time. And highest prevalence seen in children between age of 4 to 6 years during their schooling, and seasonal peaks of infection occurs from December to February in Western countries during their winter months. Okay, that's all. And these are my references. Okay, thank you very much for your attention.
Let me start talking until he sets it, because we are already running short of time. Actually, briefly in the next 20 minutes, what I'm going to talk about is clinical manifestations of acute respiratory infections in children. As we all know, I think the previous speakers has enoughly emphasized that how important the respiratory tract infections to us, those who are treating children, because it's, I think even in a ward setting, majority of admissions, especially these days, are due to respiratory tract infection, and even outpatient, it is much more. And you have seen the data which was given by the previous speakers. It's a major cause of morbidity and mortality in our settings. But what I'm going to talk is, when a child presents with a respiratory tract infection, we all know the typical signs. They come with cough, colds, bit of headache, flu, But what we should not miss in our context is the sinister signs or the signs of respiratory distress, which needs hospitalization and attention. That is what I am going to stress in my presentation, as well as atypical non-respiratory symptoms that children come due to acute respiratory illnesses. In the majority, respiratory tract infection starts at upper respiratory tract infection. That is the portal of entry of the pathogens into the respiratory tract. And it settles there. In minority, it proceeds to go to the lower respiratory tract infection. There are so many factors which decides whether the infection will resolve at the upper respiratory tract or whether it will go down. So those were also discussed before. It is environmental as well as it is inbuilt from the patient itself. When you're talking about, especially these days, that we have, due to the improvement of health services, we have got a lot of children who are having other comorbidities, like especially chronic lung disease children, children with congenital heart diseases. Those children, they easily end up in lower respiratory tract infection rather than settling of upper respiratory tract infection. Then those with immune deficiencies, especially those problems with mucociliary clearance, they can't prevent the pathogens going into the lower tract, so they will also end up getting lower respiratory tract infection. And again, those with prematurity, due to so many factors adding together, immune deficiency, poor innate immunity, they will also end up with getting lower respiratory infection. Going on to multivitamin deficiencies, we all know vitamin A is the main micronutrient, which is very, very important, which will prevent progression of the respiratory tract infections. There are other environmental factors as mainly to do with environmental pollution, as well as social factors, especially to do with overcrowding and poor compliance to medical care, especially those asthmatics who are not on regular prophylaxis, defaulting prophylaxis. They are more prone to end up with a lower respiratory tract infection, even if they get a small upper respiratory tract infection. Just to retreat, we should all know where the upper respiratory tract infections end and where the lower respiratory tract infection starts. By definition, the upper respiratory tract infections are the infections above the vocal cords. So, and all below are labeled as lower respiratory tract infections. So laryngitis, tracheitis, and down below all are lower respiratory tract infection. So etiology wise also, 99 or more percentage of infections of upper respiratory tract nature are bacterial other than the viral, other than the otitis media, whereas bacteria starts predominate when the lower respiratory tract is infected. Moving on to respiratory distress, that is the important thing to find out when we see a child with respiratory symptoms, because this is the time we have to take action, where Chandni is going to discuss about the management of acute respiratory tract infection. So what are the signs and symptoms which we have to look for when we see a child with presenting with acute respiratory illness? We will look for signs of respiratory distress. So it is not one single entity or single measurement that we are going to do. It has to be a collection of all factors, and we will have to decide whether this child is in respiratory distress and whether this child needs admission. Especially the parameters that we are going to look for is use of accessory muscles. All of us know, so especially for the medical students, we normally breathe and nobody sees that we are breathing. But when there is a problem going on, they start using accessory muscles. That is why we see signs of respiratory distress or use of accessory muscles in anybody with respiratory distress. Then there are measurable parameters, mainly the saturation, respiratory rate, and the heart rate, which goes up due to the in child with a respiratory distress. So these are the basic parameters. In a neonate and up to 2 months, the cutoff of respiratory rate is 60 breaths per minute, and bigger the child, the threshold becomes less. And in a bigger child, 5 years or more, a respiratory rate of 30 or more has to be considered as a marker of respiratory distress. Same way, there are parameters for heart rate as well, which I did not include in my presentation. Then the next sign is presence of accessory respiratory noises. There are, other than the breathing noises, there are other accessory audible noises which you hear in a child if a child is in respiratory distress. The main thing is grunting, what we call as kendrigano, forceful expiration and making a noise. If a child is grunting, that is not normal as well. As in adults, they don't grunt for unnecessary things, for attention seeking. If a child is grunting, we will have to think and consider the child's respiratory distress, and we will have to admit this child. So this child needs attention. We have to immediately attend to this child. Head bobbing, especially in infants. If a child is in acute respiratory distress, there will be head bobbing. That is, with each breath they take, their head will nod. So this is a very sinister sign in infants with acute respiratory distress. I think you all will appreciate. So each and every breath, this child is nodding the head. Tracheal tuck. This is usually seen in children who are big. With each inspiration, they will have a suprasternal compression. Yeah, let's go.
For it. Funny, huh?
Sorry.
No,
And finally, most of the time, what we see is recessions. When we are talking about recession, there are intercostal as well as subcostal recessions. So both these can be seen in children who are having respiratory distress. Yeah. So if a child is brought to you with your initial assessment, if the child has markers of use of accessory muscle, the factors that we discuss, if the child is grunting, if the child is tachypneic and tachycardic, you always have access to check the pulse oximetry. If the pulse oxygen, the saturation is more than 94%, if the child is breathing air, you will consider this child is in respiratory distress. So this is a child who needs urgent attention and who will need immediate care, and you have to consider hospitalization as well. So minding you, one child might have few of these symptoms, but considering the child's background. So if the social circumstances is very unreliable, bringing back the child for a review is very unreliable, and especially the day-to-day activities, especially eating, drinking is affected, the urine output is less. So all these things have to be considered, considering the overall picture of a child in distress and considering admission of a child. What are the other factors we have to consider, clinical features, when we are thinking a child with acute respiratory infection? Especially those are the features of respiratory system that we talked of, but there are other features where the infants and children can present with non-respiratory symptoms when they are having a acute respiratory infection. Especially in neonates, the poor feeding is the commonest thing. The first thing that they do is stopping the feeding. So you might not hear a cough, you might not hear a nasal discharge. If a neonate is having poor feeding, you will always have to consider respiratory tract infection as well. And other features, excessive crying can be just a upper airway obstruction, nasal block, or it can be a evolving pneumonia. And temperature. As we discussed, hyperthermia or febrile illness is a marker of respiratory tract infection, but in neonates, as they do not have pyrogens, enough pyrogens, as well as body fighting capacity to produce fever, they will be hypothermic. So you will have to consider respiratory tract infections, because it is one of the commonest foci of infection where a neonate gets, or an infant of first 6 months, you will have to consider of respiratory tract infection. Of course, poor activity and grunting, as we discussed. So this is a very, if you see an infant, these are very, very non-specific signs. You don't suspect a child is having pneumonia. And eliciting clinical signs is very, very difficult in a neonate. So then these are the instances where we have to depend on the radiological investigations or biochemical hematological investigations, because our clinical skills might not work because these are very non-specific signs. Just what I want to emphasize here is, in an infant, smaller infant, it is not always respiratory symptoms that are signs of respiratory distress that they present. There can be other atypical features that they come up as well. This is another place that where we miss respiratory tract infections in children, especially when it comes to the pneumonia stage. They will not have much of upper airway symptoms like cough, coryza symptoms. They will just come with a shoulder pain. If you just go back to our undergraduate level, we all know, due to the common innovation, if you get the phrenic nerve involvement, stimulation of irritation of phrenic nerve, you can get shoulder tip pain, and a child can just come with shoulder tip pain and having a pneumonia. So careful evaluation is very, very important, because so other thing we have to consider when we are talking about atypical presentations, other than the referred pains, the atypical presentations, especially due to COVID-19. These atypical presentations can happen due to antibody response in MIS-C and MIS-N, but sometimes during acute stage also, they can have non-respiratory presentations. Few examples are COVID-19, they can just present with diarrhea and a febrile illness. Same way, I think we all see few here and there cases of influenza A, sometimes just fever and diarrhea, but they don't have any respiratory tract infection. So especially viruses, they don't restrict their attack only on the respiratory system. They can always go and attack other systems as well. So we have to keep in mind, if they are coming with atypical symptoms, whether this is a respiratory tract infection. Of course, when the typical respiratory tract infection gets complicated, they can have multi-system involvement, involving from head to toe, with cardiac involvement, liver involvement, coagulopathy. So that is a part of the illness. But what I am trying to say is, in even initial presentation, they can have other system involvement. So this is a very brief lecture. If I just want to summarize what I have been telling is, in clinical practice, acute respiratory infections are very, very common. In fact, it is the commonest illness that we see. And when we are talking about acute respiratory infections, they present with classical symptoms of cough, cold, fever, myalgia, headache, all those, and classical signs that we can elicit. But it is not always the case. They do come with atypical presentations, especially in smaller children and infants as well as neonates, which we have to always keep in back of our mind. And we all should know how to find out, or how to point out how to find out a child with respiratory distress, because these are the children, even though the illnesses are common, complications are rare. So these are the children which we have to quickly pick and attend. Otherwise, they can go into complications of respiratory illness, which can be respiratory failure, secondary cardiac arrest due to hypoxia even. Thank you.
I will be doing most of the ideal diagnosis methods available, but I will give you a pinch of salt about what we can do. I don't have to tell you again and again, most of these respiratory tract infections are due to viruses, but we can have bacterial pathogens. As Pruvanti told you, it's mainly low respiratory tract infections. So early diagnosis is important, because this affects all the exposure to antibiotics, hospital stay, comorbidities, and everything. Quality laboratory report depends on many factors. I used to tell intern house officers, rubbish in, rubbish out. If you give us a rubbish sample, the report is also a rubbish report. So if you can give us a good sample, I mean, most of the children cannot give a good sample that I understand. And time of collection, transport and storage conditions all matter. Then selection of the test, accuracy of the run, experience of the MLT if a microbiologist is not supervising the bench. Quality control of the test is also important. Most of the tests are qualitative, but some are quantitative. So what are the samples? If the child can give a good cough out sample, sputum, that's good. But if they cannot do that, we go for gastric aspirate. Gastric aspirate, best early morning. Throat swab, if you are suspecting viruses and infections around tonsils. Bronchoalveolar lavage, considered as the best. Then you have nasopharyngeal washes, nasopharyngeal aspirates, and nasopharyngeal swabs. Pleural aspirates, lung biopsy and pleural biopsy are actually considered invasive samples and your last choice. Urine can be used for, in other countries, for pneumococci and Legionella. I think Legionella urine antigen test is available in the private sector, but not pneumococcal antigen testing from urine. This is a good sample of sputum. You can see yellowish sample. In other countries, they do it with dilution. So they request you to set at least 2 ml of sample. However, in Sri Lanka, whatever the amount we get, we don't refuse, because we know even other countries, they don't refuse. They just put some comment about the quantity, because we know it's difficult to get from a child. Less than 2 hours transport time is the best. In other countries, they do quantitative testing. So they don't mind refrigerating, but in our country, refrigeration is a problem. We can't isolate Haemophilus or pneumococci, which are very sensitive to the temperature. So in our country, we don't recommend you to keep it in the refrigerator. I don't have to stress this. Next thing is about rejection of the sample. Mismatch of information on the label and request, because we don't know to whom we are issuing the report. Inappropriate transport temperature. For bacteria, if you have kept it in the fridge, sometimes nurses write sample is in the fridge. Actually, we process, but we don't like to process that type of samples. Excessive delay allows common cells to multiply. So those samples are not reliable, though we issue reports. Sometimes they send the samples which were in formalin. This was because of the misunderstanding of what is to send for microbiology, what is to send for histopathology. And sometimes we get empty bottles and samples of questionable relevance, because we are not sure whether we have got sputum or saliva. Leaking samples, you know, are not accepted in any setup. So we can do conventional testing using culture and antibiotic susceptibility. Then we can go for immunodiagnostics, that means serological diagnosis. Then PCR and RT-PCR. RT-PCR you do for what? PCR is for DNA viruses, RT-PCR for RNA viruses. So depending on your pathogen, you go for these things. In the past, there were some developments in molecular platforms. As far as I know, Candy Teaching Hospital has this 21 pathogen detecting platform which detects viruses as well as bacteria. Other than that, I'm not aware whether it's even available in private sector. Point of care testing. What are the point of care testing available? For influenza and COVID, point of care testing is available. Those are immunochromatographic tests which shows bands like the NS1 antigen. Microscopy we can do if we are doing qualitative testing, because in quantitative testing we have to homogenize the sample by using lytic agents. When you use lytic agents, you cannot see WBC. But there is a problem when we do microscopy from non-homogenized samples, because we might miss somewhere where WBC comes. We usually go with trough criterion, 10 epithelial cells to 1 WBC as bad. If you get other way around, like 10 WBCs with 1 epithelial cell, good. But this can go into Murray-Washington classification where you go with 25 cells, 25 WBCs and less than 5 epithelial cells. But in a busy lab, you cannot do this counting. It's a low power counting, not high power. You have to give the WBC count in low power. If they say it's done in high power, it's not relevant. Blood culture is not mandatory in respiratory tract infection. Most of the time, it's negative. In pneumonias, you can get, and majority of pneumonias actually, pneumococcal pneumonias, which give positive blood cultures. You can see squamous epithelial cells, and you can see pus cells. Here, it's more epithelial cells. Here also more epithelial cells. But here, you can see lot of pus cells. But most of these organisms are your upper respiratory flora. By looking at this gram stain, we cannot decide about the pathogen. When we do ideal, we have to use lot of resources. In that, we plate in a single plate, undiluted sample, then we homogenize. After homogenizing, we do this. You take homogenized sample into normal saline for a dilution, then we plate the diluted sample also in another plate. In that, if you get the pathogens in diluted sample as well as undiluted, you consider it as significant. You can see this has 5 types of colonies. So it's difficult to say there is a pathogen, maybe viral infection here. Here you get one single pathogen. This is a pseudomonas. This is staph most likely. This is more likely gram negative. If you get like this, you know, without doubt, you have got a pathogen. But most of the time you don't get it like that. Bacterial cultures are labor intensive, need lot of laboratory facilities, and turnaround time is about 48 to 96 hours. So this has its inherent disadvantages, but you get the antibiotic sensitivity test. For viruses, you can have cell cultures and see cytopathic effect, heme absorption, but these are now even outdated in most of other countries because these takes time. And if a cell line gets contaminated, nothing done for about 1 week. This gold standard is now more and more replaced by molecular diagnostic methods. You can now have a lot of PCR testing done for most of these viruses. The advantage is you can detect most of the things you cannot grow. Shell vial method is one form of cultures which gives rapid turnaround time. However, PCR is the norm in most other countries. Even for mycoplasma, they go for PCR. For Sri Lankan patients, if you need PCR, it's a problem of obtaining. Most of the institutes, they don't do. However, MRI Virology provides service for influenza. They are the reference lab which provides Sri Lankan isolates data for WHO, where WHO takes the idea about circulating influenza and para-influenza viruses. These rapid immunoassays you can do. These are most of the bedside tests with short turnaround time, and you can use latex agglutination, lateral flow devices, and optical immunoassays. Not available in our country, but will give you good turnaround time, unlike cultures. Direct fluorescent antibody test can be done for human metapneumovirus, adenovirus, RSV, and para-influenza viruses. However, for direct fluorescent test, you need to send a sample with cells. You have to get a good sample. Serological tests usually develop after 2 weeks of initial infection. These are good for serological survey. And atypical pathogens, you go for serological diagnosis. To do this, ideally, you need acute and convalescent serum, because serological test either changing negative to positive or fourfold rise is the ideal. In other countries, they keep the first sample and they run the first sample with the second sample so that errors are minimized.
Boss, කොහොමද?
So molecular tests also have their own disadvantages. Quantity, quality of specimen collected, and the assay sensitivity all matter here. They say optimal results when you collect the sample 3 to 5 days after onset of symptoms. Again, specimen transport time, and for viruses, you need viral transport medium. All these samples should be tested within 48 hours. There are array of, we call them NATs, that is nucleic acid amplification test for different viral pathogens. And I told you there are viral and bacterial combined facility also available. These are called multiplex assays because it has more than one panel to detect multiple pathogens, atypical pathogens, as well as common viral pathogens. Less expensive than RT-PCR, and you get, because multiple assays are going, you get pathogens most of the time. But identification of subtypes, confirmation by other tests are needed. The problem is these are expensive and you need trained people to run these panels. There are antibiotic resistant markers, genes you can detect. There are separate available tests like CARBA-NP for detection of carbapenemase, MEK gene detection for MRSA. However, what I have to tell you is what we are doing in our countries, qualitative test. We don't go for quantitative test. Even to give qualitative test, it needs lot of resources. At the moment, resources are actually very limited. Ideal sample should be taken before starting antibiotics, because antibiotics will have pressure on selection of organisms, and you might be sending us selective flora for culture. So with that, I will finish my lecture, but my underlying message is good sample, good report. Thank you very much.
Good morning. So thank you for giving these opportunities. Yeah, so I've been talking about radiological diagnosis of acute respiratory infection, especially with regard to children. Yeah, so I think maybe prior lectures have been discussed this one, so why it is important. So pneumonia is one of the most common cause of mortality and morbidity in pediatric patients. And early diagnosis management is critical for short and long-term health outcomes. So if the clinical picture is difficult, and you may go for imaging. So role of radiology. So you can divide basically into 4 imaging methods: chest X-ray and lung ultrasonography, CT, and MRI. So regarding chest X-ray, so this is the most common investigation you have requesting for respiratory infection. But having said that, we have to consider especially in pediatric patients, dose of the radiation. So the chest X-ray is not totally recommended according to guidelines in most of the uncomplicated cases. And as a baseline, so we can request only PA views. So lateral X-ray should not be performed routinely. And what about the follow-up radiograph? So usually follow-up is not required in those who have previously healthy and recovering well. So unless it's complicated, unless it's around pneumonia, or you suspect collapse or persistent symptoms. So what are the patterns? So maybe it's very difficult to comment on the chest X-ray, especially in pediatric patient, because it's a little bit different from the adult picture. So basically, patterns can be divided into 3 groups. So mild interstitial changes, and then simple or uncomplicated pneumonia, so like lobar consolidation, and then post complicated pneumonia, so example pneumonia with empyema or necrotizing pneumonia. Yeah, so I talk about the lobar pneumonia first. And so when you take chest X-ray, so this PA view, so you can see there's some classification in the right upper zone. So it's a homogeneous one. So we have to consider there would be differentials for opacity like this. Either it could be a mass lesion, or can be collapse, or can be consolidation. So those 3. So how do you differentiate? And so if you take collapse, and there should be some volume loss. So I'm mainly considering of the consolidation here. So because I didn't put any pictures of collapse, so mass lesions. So if there's a collapse, there should be volume loss, and maybe rest of the lung may be normal, and the margins may be very demarcated. So if it is a mass lesion, there can be some mass effect on the rest of the tissues. So the trachea can be shifted to the other side, and so there can be and the homogeneous appearance. There can be calcification, there can be rib abnormalities, there can be necrotic changes. But what happens in the consolidation? So you can see some air bronchogram. So air bronchogram is the key feature with some adjacent. You can see some inflammatory changes, reticular nodular patterns. So not well defined as consolidation. So with the clinical history, we can come to a conclusion. So this is consolidation. So it's a lobar consolidation. So maybe associated with, most likely associated with the specific bacterial infection, like pneumonia and Hemopracy will be Klebsiella. Right. So then, this is not a good X-ray. I'm sorry about that. It's a little bit whitish. So interstitial pneumonia. So if you can see some reticular changes more than the vessels, so you think maybe not vessels, so a little bit more prominent than the vessels. Maybe some reticular changes diffuse or bilateral. So that is maybe due to interstitial pneumonia. So interstitial infiltrate somewhere here. So maybe not obvious as a consolidation. So these features can be due to usually due to viral infection or else atypical bacterial or influenza or RSV. Right. So what about the bronchopneumonia? So bronchopneumonia usually multiple small nodular or ectonodular opacities, which tend to be patchy and or confluence. So you can see in the right lobe, not like the left lobe, there are some patchy consolidations area, focal infiltrations, this area consolidations. So involved in the upper zone, mid zone, and lower zone as well. So but the left lung is grossly unremarkable. So this is bronchopneumonia in only more than one lobe. So it's bronchopneumonia. So it's usually with gram-negative bacteria, staph, or maybe some fungi. So these are the basic picture of the X-rays considering the respiratory tract infections. So what is this one? So this is a round pneumonia. So basically you can think about the mass lesion because this is very defined and so opacity. And but sometimes you can see air bronchogram through the lesion. So how do you differentiate this from the mass lesion? So maybe mass lesion, unlike this one, may be very defined. You can't see any air bronchogram. Maybe there's some calcification. Maybe there's some rib abnormalities and the history. So if you follow up this X-ray, maybe so you should follow up this X-ray because as I told earlier, so this is one indication for follow-up. So we never know, so you can get a true mass. So if it is around pneumonia, it will disappear. Yeah. So what are the limitations of chest X-ray patterns? So even though we think about this can be due to bacterial or viral. So several studies has been conducted and decided that usually generally unhelpful for deciding on a potential causative agents can be viral or bacterial. So it's like an assumption. So we can't say 100% this is bacteria, this is viral because there is overlap. And also age and other comorbidities and immunological status, they can modify the radiological manifestations. So they can be a typical picture. And of course, the quality of the film. Maybe child is not very cooperative. And and of course, reader's experience. So what is the next step? So lung ultrasonography. So what are the advantages? So low cost when compared with the X-ray and simple method. You can do even you can take a portable ultrasound machine and it's rapid and it's radiation free and real-time examination, and you can do even rural or remote sitting without X-ray facilities. So these are some figures, lung ultrasound versus chest radiograph. So this is a recent study last year. So it says in ultrasound, it's more sensitivity is more than the chest X-ray when detecting pleural effusion, pneumonia, pneumothorax, and pulmonary edema. So you can see this sensitivity is around 92% pleural effusion, chest X-ray is at 9%. So all these are regarding 90s, but the sensitivity of chest X-ray is 39, 77, 46, 73. So it's more sensitive ultrasound. And specificity is more or less equal to the chest X-ray. So this is more important because of the pediatric population, because of the radiation. So we know there can be cumulative effect of radiation the lifelong investigations. So basic ultrasound picture. So this is the normal appearance of a lung. So when you keep the probe here, either linear or curvilinear probe, so you can take, you can see A lines. These are horizontal lines parallel to the skin or pleura. So these are normal, the normal A lines appearance. But what are the B lines? B lines are vertical lines. So there can be, this can be due to, this is due to reduced aeration in the lung parenchyma. Right? So there are some several stages, and when it is becoming more fluid, then you can see the consolidation. So consolidation is you can see the hypoechoic area with some hyperechoic white color dots. It could be branching pattern. This is air bronchogram. You can see in the consolidation pattern air bronchogram from the ultrasound scan. So you can diagnose consolidation easily from ultrasound scan. So it's play an important role in evaluating peripheral consolidation and pleural effusion and of course empyema. So what are the limitations? We can't identify the deep and abnormalities and the structures distant to the chest wall. So if the distant, peripheral lungs is normal, if there's a consolidation in the middle part, maybe medial segments, we may miss. So these are these are some examples. So you can see the chest X-ray. So middle lobe opacity. So when you do the ultrasound scan, you can see the branching pattern, hyperechoic area. So this is the air bronchogram. So this is the typical appearance of consolidation. And this is one picture. So you can follow that. If so, you can see the depth is reduced in this one. And after further follow-up, so consolidation has resolved. So this is a normal lung markings, normal A lines. This is another example. You can see the right hemidiaphragm is elevated when compared to the left side. And so you think it can be liver, but it's better to do an ultrasound scan to assess any basal pleural effusion. So when you do the ultrasound scan, you can see large effusion in the right base. So you can aspirate, after that can resolve. So this is a normal lung after aspiration. You can see the air normal artifact. So this is another example. So right side basal pleural effusion. And so what is the important thing about the evaluation of pleural fluid, pleural effusion, is whether it is having any septae or any echogenic foci, any suspicious for infection. So if there are multiple septae, maybe not helpful doing aspiration. So maybe you can aspirate only one locule, or whether it's need surgery. So like that. So you can assess by the ultrasound scan. You can characterize the effusion very well with the ultrasound scan. So these are the septae within the effusion. Yeah. So then we discuss about the next step. So CT. So CT is confined to the basically for complicated pneumonias because of the radiation. So because it's higher radiation dose than X-ray. And for example, so you can assess empyema, so not confirmed by the ultrasound scan, and maybe some immunocompromised children, any other abnormalities or necrotic lymph nodes, any abscess formations. The pneumonia is poorly resolving, and of course, underlying the pneumonia, cause of pneumonia such as foreign body or sequestration, and maybe to guide the biopsy to assess the particular organ. So, but the disadvantage is the radiation, and maybe we need the sedation or anesthesia. So this is another example. So you can see a rounded opacity in the left mid zone with the air fluid level. So it's typical secondary lung abscess. And this can be due to underlying congenital abnormality like CCAN, cystic anemia. So at this point, you may need to go ahead with the CT to assess further. So this is another example for CT. On the left side, there is some effusion, but you can see there's some peripheral enhancement. So this is contrast enhanced CT, peripheral enhancement. So we call it empyema. And in the lung, of course, there are some cavitatory area. There are no peripheral enhancing area. So there are this lung parenchyma is not enhancing. So these are necrotic changes. So empyema with necrotic changes in the lung. So this type of complicated cases you can assess with the CT. So what about this? So when you can see this some opacification in the right lung and paratracheal widening, some inflammatory changes in the right lung, highly is prominent. What about this bronchi? So left main bronchus. So you have to be careful with this main bronchi because these things can be missed. So you have to trace the trachea and main bronchi. So this left main bronchus is, you can see some narrowings there. So there is some opacification surrounding the main bronchus. So suspicion for lymph nodes. Then you can request CT, where this lymph nodes are enhancing or necrotic. So if these are necrotics, this can be due to pulmonary tuberculosis or extrapulmonary. Yeah, so those are the basic occasions in the CTs. So what about the MRI? So MRI in the current clinical picture practice, so MRI is very infrequently utilized in evaluation pneumonia because of the high cost and the limited availability. And also maybe patient has to be sedated, time consuming, you have to transfer the patient. So, however, so the MRI is very accurate in detecting pulmonary consolidation and pulmonary necrosis, abscess, and pleural effusion. So in research level and maybe some tertiary care centers in developed countries. May be considered in patients who have chronic diseases that might require multiple CT scans. So then you can reduce the radiation dose. So in Sri Lanka, MRI may be very infrequent, is only with very specific conditions. Yeah, so those are the basic investigations with regard to the radiology, chest X-ray, and chest X-ray, ultrasound, CT, and MRI. So the take-home message is, so you don't have to request chest X-ray unnecessarily because of the pediatric population. So you have to judge clinically, and if you think it's not resolving or complicated, and because to find organisms, we can't give organisms in the chest X-ray, and it's all happened. And so if you think it's complicated, if you think it's not resolving, then go for X-ray. And if X-ray, you are doubting over the effusion or out for effusion, don't request CT, go for ultrasound scan first. So then ultrasound scan, you can follow it up. Next step is the CT. Okay, thank you very much.
Right. First of all, I would like to thank the organizers of this very interesting webinar on acute respiratory infections, especially Dr. Ratna, for inviting me coordinating this webinar. So you have gone through the very interesting, informative presentations about the epidemiology and all the related issues and the diagnosis of the acute respiratory infections and various modalities. So here I am focusing about the management of acute respiratory infections. As you all know, it's a wide spectrum. Respiratory infections mean upper airway as well as lower respiratory infections. The management spectrum is also wide. So because of that, I will mainly focus about few important areas, important to give some key messages, and some of these things already discussed might be repeated, but again, it is just to recap what is important in the acute management or the management of these children. How do we use all these resources, especially the clinical features, radiology, microbiological diagnosis in the management of children with acute respiratory infections. So management of acute respiratory infections, as I mentioned, it's a quite variable topic, but all these things which I am discussing in this next 30 minutes can be summarized into this. So I'll start with the summary. So what are the important things in the management of a child with acute respiratory infections? So summary is, first thing, important thing is early recognition of cases of pneumonia, because the pneumonia is the one which kills the children. And it's very important to identify children with pneumonia as well as the most important severe cases. Already epilepsy has been discussed. It's one of the major killer in children, especially children under 5 years of age. And other important thing is appropriate use of antibiotics and prompt referral of severe cases if it is really requiring. At the same thing, the appropriate use of antibiotics is important because in our setup also, it's not really confined to our setup. Inappropriate use of antibiotics is seen very, very commonly in children with acute respiratory infections without evidence of bacterial infections or pneumonia, especially with uncomplicated acute respiratory infections involving the upper respiratory tract. So that is important, appropriate use of antibiotics. Another important thing is a similar importance while recognizing the causes of acute pneumonia. It is similarly important recognitions of cases do not have pneumonia. So that is important. I just mentioned which do not require antibiotics as well as many of the management, because majority of these cases, as already mentioned, due to viruses and self-limiting, especially uncomplicated upper respiratory tract infections. And apart from these management, so we can use other measures, especially as you know, in children with respiratory infections, it might be the commonest respiratory viral infections are the commonest trigger for development of asthma, or sometimes it can exacerbate the underlying chronic lung diseases. So appropriate use of bronchodilators as well as appropriate use of other supportive measures. So if we can identify the pneumonia, appropriately use antibiotics, and identify the other cases which do not require antibiotics, and use of other measures like use of bronchodilators. So all the respiratory infections, whatever the area affected, we can manage very effectively or without taxing our resources and unnecessarily or unduly developing antimicrobial resistance in these children. Okay, so as you all know, we can divide broadly the respiratory infections into two categories: upper respiratory infections as well as the lower respiratory. Upper one are the commonest, and respiratory diseases are the commonest diseases, not only in children, any person throughout the life. So rhinitis is the commonest thing. Usually it's associated with nasopharyngitis or this common cold, or sometimes pharyngitis can due to bacterial infections, especially group-based streptococcal infections. Sinusitis, again, majority due to viral infections, but again, can have bacterial infections. Otitis media and epiglottitis, very important killer if we do not recognize properly and do not act promptly, especially, epiglottitis can go into the spasms, and that would be the end of the story of that child. So fortunately, we don't see much cases. One thing is due to this improved immunizations against the streptococcus, Haemophilus influenza B. And laryngotracheitis or laryngotracheobronchitis, both involve the upper and lower airways. And pertussis also once a problem, but with the immunization, now it's not a major problem. So there are various types of diseases which involve in the upper airway. Some of these are common. Some of these diseases were common, but now we don't see much of these. Most of them are due to this immunization. Okay, so I'm just briefly discuss about the common cold, because here the most important thing about not the management, because we manage with various things, but here one of the things I just want to stress is what are the things we should not do or not effective in the management, although we use most of these medicines or various remedies most of the times. So what are the symptoms or natural history of this process, especially involving the upper airway, the common cold, involving the nasal cavity, pharynx, as well as sometimes with sinuses. Most of the time, again, a viral thing. So nasal stiffness, And sometimes they might have low-grade fever, malaise or myalgia, some systemic symptoms, or maybe have sneezing and watery nasal discharge and or cough. About 60% of cases, maybe up to 80% of cases, they can have fever, and sometimes this fever might persist about a week or maybe up to 10 days, but usually settles within few days. This sneezing and watery discharge is the same thing, and this cough. The important thing is these days, I'm sure you also coming across a lot of children with viral upper respiratory tract infections and continuing with lot of cough, significant cough involving the sometimes bouts of cough, very difficult in sleeping. So all these things are related to the upper airway involvement, and sometimes it's very, very difficult to manage completely with available drugs, because most of the time it's a self-limiting thing. But the problem is parents are very distressed because childs are they are coughing, but the natural history, it will take sometimes few days, more than a week, maybe up to 10 days, or sometimes maybe beyond that. Other thing is, the common cold is a main thing in all in the viruses, and same time, because there are more than 200 virus subtypes can cause common cold. Same features can have with the development of influenza infection, that is called flu. How do we differentiate? It's just other viral infections or uncomplicated common cold with flu symptoms, because almost all the symptoms are same, but usually in flu or the influenza infections, these symptoms are little bit worse, or child is little ill. They can have high fever in comparison to the common cold, runny nose, but runny nose and other symptoms are less common. But obviously, we might not be able to clinically differentiate, but this is just epidemiological features which suggest more suggestive of viral infection, or more suggestive of a flu due to influenza infection. So I'm not going to do details because you know, just to recap, or just to give some trigger to read about these things. It's very important to differentiate, if possible, clinically. Another, this is one of the important slide I want to stress here about before going to the management. Rather than the management, there are various things, various remedies, various cough syrups, various medical management we use in children with upper respiratory infection, especially common cold. But evidence suggests, although we use this, I'll go through one by one little bit. They might not have an effect. So there are lots of, so this is various guidelines in the world repeatedly stress about this, but still we use in our setup also throughout the world. This is a very common phenomena. This is American Family Physicians article. Antibiotics, obviously there's no difference between the outcome if we use antibiotic or do not use antibiotic, because it is most of the time due to viral infections. Carbocysteine, very frequently used in Sri Lanka also. I don't want to mention the brand name. Dextromethorphan, diphenhydramine, again, especially these days, because children are having a lot of coughs, persistently having cough, there might be some effect, but at the moment, available data or available evidence does not support, or there's no superiority to placebo in nocturnal cough or sleep quality in the child or parents. And this is echinacea, again, some plant extract used in other countries, low dose inhaled corticosteroids, oral prednisone, especially steroids used in children with upper respiratory tract infections, common cold. Again, no significant difference in duration of hospitalization, interval between admissions and discharge, mean 7-day symptom score reported by the parent or hospital readmissions, or for wheezing within 1 month of compliance. So all these things, they have analyzed various way, but still there's no place of these steroids, but still we are using, but it's very difficult to say, but sometimes we're very, very reluctant. Children, especially with some refractory cough, there might be a place, but obviously we should not use all these things, all children. That is definitely a identified fact. Even it has been proven with various evidence or various studies and even meta-analysis and systematic review. So in the management of upper respiratory tract infections, what are the key recommendations? Antibiotics should not be used for the treatment of cold symptoms in children. Over-the-counter cough and cold medications should not be used in children less than 4 years because of potential harms and lack of benefits, especially small children. And obviously, you know, we are using some codeine containing cough syrups and some various combination of these cough syrups, but they can have more adverse effects. So the harmful effect would be more especially in small children less than 5 years of age. What are the possible things we can do? Still, there are no consensus about the management of children with upper respiratory tract infections, especially common cold. Most of the time, it's a symptomatic treatment. Various studies are going on, or still we don't have convincing evidence of use of these like nasal irrigation, sometimes honey like bee products, others some of the products, some plant extracts may have some benefits, but still no convincing evidence of use of this. So what are the things we can use? One thing is saline nasal irrigation. So this is a recently published systematic review about the use of saline nasal irrigations for acute upper respiratory tract infections in infant and children. So they have concluded actually the saline nasal irrigation is beneficial for rhinological symptoms, especially relieve the nasal obstruction, upper airway symptoms, but not for the respiratory symptoms. That means especially known in the lower airway. So we can use this technique very less frequently used in Sri Lanka, but that can especially give some respiratory the relief of these symptoms, especially nasal symptom, nasal congestion. In children, we are very frequently use saline drops in small children, infants, but we don't do this irrigation. We can use this even nasal aspirator to aspirate. That is also been practiced in Sri Lanka. So older children, we can use this nasal saline irrigation, especially if they complain of nasal obstruction and breathing difficulties. Sometimes they tend to breathe through their mouth. What about these other non-medical things like honey, acute cough in children? Even Cochrane systematic review also published. This was published in 2018. What is their conclusion? Honey probably relieves cough symptoms to a great extent than no treatment or than diphenhydramine and placebo, but may make little or no declarence compared to the dextromethorphan. Okay, so actually it's obvious it's not a harmful thing, natural thing we may use, especially children with lot of cough these days. Even I recommend to use honey because a lot of steroids, antihistamine, some cough suppressants might not work in this upper airway cough, irritable cough, persistent cough, and children are very distressing and they end up with post-acute vomiting these days following viral infections. So they have honey probably reduce cough duration better than placebo and salbutamol. However, still no strong evidence for or against using honey. That's the thing. They might be effective in reducing symptoms in children with upper respiratory infections, especially with persistent cough. So for probiotics, this is again a hot topic. Use of probiotics in various ways. We are using in GI conditions, but respiratory infections, respiratory conditions also, there might be a place for probiotic, but still there's no consensus about the how they use, what is the durations, what are the types of microbes used as probiotics. Still, the researches are going on. So still we cannot know, the recommendations are not there. The use of probiotics in upper respiratory tract infections. Other important thing is this physiological respiratory infections. What is that? So obviously infection is not a physiological thing, but still it may be a physiological thing or it's a very common thing. That means we have don't have to worry. This is again a very, very common complaint in especially parents. These days, a lot of respiratory infections are going on, as already mentioned during the COVID period. They were at home, the other respiratory infections were significantly reduced and with the use of mask as well. But now again, after 2 years, they are starting to exposed to the environment, and very frequently kids are having a lot of respiratory infections one by one continuously within few weeks apart. So again, so we have to explain the parents. So it's very physiological actually. It's not even not a physiological thing. The certain number of respiratory infections can be considered as physiological due to the development of immature immune system in these children. So they are more prone to develop these infections. Once they develop these infections, they acquire the immunity to these viruses, and finally they get used to these. Simply the simple word, they get used to these infections. So the normal frequency of uncomplicated respiratory tract infection. What is the normal frequency? It's a variable thing, but roughly less than 5 years. Children, there might be 6 to 8 episodes per year. In our tropical countries, it's going on throughout the year, but other Western countries or the temperate countries, it's mainly autumn and the winter periods, these respiratory infections. And the older children, 6 to 8 years or 6 to 12 years, about 4 to 5 per year. So this is very, very normal to have recurrent respiratory tract infections, uncomplicated upper respiratory tract infections most of the time due to viral infection. So that is another part of the management, not only the managing the disease, we have to especially counsel or reassure the parent. It's a very, very normal phenomena, or we can use the term, it's a physiological phenomenon. So without discussing the details about the other upper respiratory tract infections, I am just jumping into the lower respiratory tract infections to discuss a little bit about the pneumonia, to emphasize some important points in the management of a child with lower respiratory tract infections, especially pneumonia. So obviously, pneumonia is an infection of the lower airway. It's mainly the involvement of the lung parenchyma and leading to the infective inflammations of the lung parenchyma. You know, the alveolar spaces are filled with various inflammatory exudates and the blood. So there are 3 types of definitions of pneumonia: the community-acquired, the hospital-acquired pneumonia, and the ventilator-associated with pneumonia. But mainly the acute respiratory infections. Now, the important thing is the community-acquired pneumonia in children. So rest of the discussions, I mainly focus about the CAP, or the community-acquired pneumonia in children. So as already discussed, this is one of the most common serious infections in child, and most importantly, it is leading to the one of the main leading cause of mortality. Still, it's one of the leading cause of mortality in developing countries, not only developing, but developed countries also. Still, we see some deaths due to pneumonia in children, especially small children. And other important thing is its utilization of these healthcare facilities, hospital admissions, use of antibiotics, various management method, oxygen, respiratory supports. So the significant proportion of healthcare utilization is also still is there due to the lower respiratory tract infections, or the pneumonia involved in the, or the lung infections involved in the alveoli and the lung parenchyma. As already discussed, still I just want to stress this thing. Even the pneumonia, up to 70% of cases may be due to viruses, or upper respiratory tract infections. Over 90, maybe 95% of cases due to viruses. But here also, maybe up to 70% of cases due to viruses. You know, there are various viruses can cause pneumonia in children. And bacteria, already discussed: Streptococcus pneumoniae, Haemophilus, group S Streptococcus, Staphylococcus, Chlamydia, Mycoplasma, and we should not forget Mycobacterium tuberculosis, although it's not an acute leading to acute pneumonia, but that is one of the important pathogens which leading to lower respiratory tract infections. Another important thing is mixed infections, the infections with both bacteria and viruses. Various studies have identified up to 30% of cases, it's due to mixed infections due to viruses and bacteria. And even 2 or more viruses can infect at once. There are several studies proven that. Okay, so the main important, the frightening thing, especially in parents, pneumonia, especially when it's involving the lobe pneumonia, lobe. So it's obviously the diffuse consolidation involving the entire lobe, like that. So you can see this is a normal lung with a consolidated lung. So consolidation means the alveoli are filled with various inflammatory cells, infiltrate, exudate organisms, and there is the progression of these changes, congestion initially, then red hepatization, and the gray hepatization with RBC breakdown, and finally resolution. So the lung, the air-filled balloon-like structure become a solid structure like a liver. That's one of the main thing which we use in the diagnosis of pneumonia radiologically, because the lung become a solid structure. And the bronchopneumonia is involving the suppurative inflammations. This is localized to around the bronchi, patches of consolidations, and it's in comparison, or in contrast to the lobar pneumonia, the bronchopneumonia, it usually affects the both lungs and or most of the time all the lobes, and not confined to a single lobe. So how do we diagnose pneumonia? Obviously, we have to use various the methods. But clinically, this is mainly for other, especially third world countries who do not have proper the medical involvement, especially the care of doctors. WHO have identified or given a definition of pneumonia. That's very simple definitions. Fast breathing with lower chest syndrome. So it's considered as pneumonia. So the fast breathing, obviously, has been already discussed. We have to get the tachypnea. The tachypnea, that is according to the child's age, the respiratory rate is changing. So we have to get it properly. Tachypnea with lower chest indroving. There are various studies and recent study. It's not a recent study, but one of the main study, they have identified the sensitivity of this method is 74% and specificity is 67%. The sensitivity and specificity is low. So in a country like Sri Lanka, which have a very good infrastructure, especially related to the healthcare facilities and access to medical people. So we have to go beyond that in the diagnosis of pneumonia. So we have to take a history, physical examination, especially the signs of lobar involvement, decreased breath sounds, crackles, and bronchial breathing obviously indicate in acute situations, previously healthy child, consolidated lung, and we can use the investigations to confirm our diagnosis. So other important thing is the severity assessment. The children with pneumonia, if they develop significant involvement of the lung parenchyma, they can end up with hypoxia or later stages in hypercarbia. So with that, the body, the physiological response in the body to hypoxia or hypercarbia, try to increase the minute volume. So the minute volume is the tidal volume into respiratory rate. So then we can see how the body is going to adapt as features of severe pneumonia. So what are those? Simply respiratory rate can be increased to increase the minute volume, to improve the oxygenation. So tachypnea, if the tachypnea is very severe, suggestive of sick child is in significant respiratory distress. Retractions, the body is trying to increase the tidal volume. So to generate more negative pressure, the body is trying to expand the chest. So then because of this pressure differences outside than the inside the chest, leading to intercostal retractions. Tracheal trach is also same, inward pulling of the trachea just above the sternum, again involvement of the accessory muscles. All these accessory muscles pulls the chest outwards and upward to increase the tidal volume, that is to increase the minute volume. So these are the features of severe pneumonia. So I'm just stressing these things. It is very important to identify children with features of severe pneumonia. Grunting, again, especially in small children, this expiratory sound due to breathing, again partially closed glottis. The body is trying to generate some PEEP to prevent the airway collapse. Nasal flaring, again, this is to reduce the airflow, the resistance in the airflow to get more air. Head nodding, again, is associated with contractions and relaxation of the sternocleidomastoid and scalene muscles. These are features of severe disease. Just other types of investigation, especially the chest radiograph, already discussed in details about the use of the radiological diagnosis in children with or suspected pneumonia. Chest X-ray is again another thing. So although it is not routinely recommended, there are various advantages of doing chest X-rays, especially if you consider a complicated or severe cases. So then we can identify the type of distribution, whether it's a lobar bronchopneumonia. If it is a lobar pneumonia, what is the exact area of lung involvement, what is the exact lobe or the segments, and obviously the progression of these conditions or the improvement of the conditions, we can monitor not only the clinically, radiologically also we can monitor. And other important thing is the identification of complications, especially pleural effusion, abscesses, pneumatocysts like complications. We can assess through the chest X-rays, and if further investigation needed, as Dr. Ajinta mentioned, we can do CT and further imaging. I just show you this is important thing because still even some postgraduate training in pediatrics still don't know about the use of the silhouette sign. Very important, very simple thing to identify the lobe which is affected in this pneumonia. Actually, the correct term should be the loss of silhouette because of this lungs. You know, the lung contain the air, so because of that is radiolucent. In chest X-ray, lung is black, and the heart and the other soft tissues, they are radio opaque. So because of that, they are white. So simply chest X-ray is a film of black and white and leading to some changes. But other important thing is chest X-ray is a 2D film of a 3D structure. So because of that, some of these changes are overlap. So because of that, we have to use some principles in the assessment of, especially in the silhouette sign, or the identify the which lobe is affected. So in normal chest X-ray, the borders are clear because the heart border, heart is, you can see the heart is surrounded by the lung. So radiologically black colored lung, the heart is surrounded. The white heart in radiology, the chest X-ray white heart is surrounded by black color lung in the X-ray. So, but if something filled in the black or the lung, or it's become consolidated, so it become like liver-like structure. So then this area also become white. So white and white. So here is also white thing. Here is also white thing. Probably you can see the mouse point. You know, can you see the mouse point? Okay, right. Anyway,
Yes,
so the both areas become white and white. So then we cannot differentiate this border. So that is the principle of using the silhouette side. The right heart border is the formed by the because this just adjacent to that is the right middle lobe. Here the right middle lobe, and the diaphragmatic border you can clearly see because it's just above that is the right lower lobe. And here the left lower lobe and left heart border is clear because it's contained air in the lingular lobe of the lung, left lung, and here the upper lobe. So if the adjacent area of these borders are filled with inflammatory exudate, or the lung become liver-like structure, that also become white in color. So then white and white, we cannot differentiate this border. That is the principle of silhouette sign. I'll go through very quickly. Right upper lobe pneumonia, you can clearly see the opacity here, and there's no collapse. If there's a collapse, this transverse fissure should goes up. So you can see the heart just adjacent to that is the middle lobe. This is suggestive of consolidation as well as the collapse, because the transverse fissure should be transverse, but now it's given up. So there's a collapse as well. Right upper lobe. And here, so you cannot see the right heart border here. So because the adjacent right middle lobe also get, or the radiologically become liver-like structure and white. So we cannot see the heart border. So this is obviously right middle lobe pneumonia. Here you can see another right middle lobe pneumonia. You can clearly see the transverse fissure below the transverse fissure. So this is the middle lobe involvement, some segmental involvement here. And the lower lobe, here the both the middle and the lower, so you cannot see the right the diaphragmatic border. So it's obviously the lower lobe is of it, because just above the diaphragm the right lower lobe is there like this. So you have to get it with the anatomy. And here, so you can see the right heart border is clear, right diaphragmatic border is also clear. So then what? So then is possibly right lower lobe, the upper segments, which is not over the diaphragm, but right heart, or the right lower lobe is a pyramid-like structure. The upper part are not lying on the diaphragm, and it's obviously not touching the heart border, because heart border is touching the middle lobe. So here is possibly involved in the right upper lobe. So that is why this important is use these principles just to give some idea how do we use these principles. Left side, left upper lobe involvement, obviously, and the lingular lobe involvement. You cannot see the left heart border here, the left heart border, but the diaphragmatic body is very, very clear. That means there is definitely nothing in the lower lobe. Even the shadow is in the lower part of the or the left lower zone, but it's obviously involved in the left upper lobe. The part of the left upper lobe here involving is the lingual lobe, because obviously there's no left middle lobe. Right here also you can see significant opacity just adjacent to the left heart border, but still the heart border is very clear. That means no problem in the lingual lobe, so it's obviously involved in the lower lobe. Like that, you can use these principles, and the round pneumonia, round-like structure can happen at any lobe, anywhere. Sometimes even the hidden part like this, behind the heart shadow. So round pneumonia, especially happen in small children, because it's the pneumonia, local pneumonia happen is once the inflammatory focus is there, then it spread throughout the lobe due to because there are some connections in between the alveoli, like process of bones and channels of canals of Lambert. But small children, these collateral ventilatory or the connections are not well developed. So because of that, they are confined to some restricted area. So then we can see these inflammatory changes or the consolidations as a round pneumonia. And the other thing, so I just gone through this lobar pneumonia and the bronchopneumonia. So involving the patchy areas of consolidation, usually bilateral, and involving the most of the time involving the all three zones in the both sides, involving the like this side of patchy areas of consolidations, subsystem of bronchopneumonia. Okay. Further diagnostic method, blood culture, obviously discussed, but I just want to stress is, even though we do blood cultures in children with pneumonia, the gain is very, very minimum. Usually it's less than 10%, and most of the time it's less than 5% is Streptococcus pneumonia. One Sri Lankan study, they have just identified maybe it's just a 0.5% in blood culture positivity in children with bacterial pneumonia. And we have to get proper respiratory samples. The gold standard is actually get a sample directly from the lung puncture. Obviously, we cannot do as it is an invasive procedure, and we know, and obviously no need to do. And we can get sputums, nasopharyngeal aspirate, gastric aspirate. But obviously, that is another thing I want to stress is, if you want to diagnose pneumonia or get the etiological agent of pneumonia, don't do gastric aspirate, because gastric aspirate is organisms in the stomach, and usually these normal or other organisms are died in the stomach due to its acidity. But even though we can, sometimes the cultures might be positive, but we cannot say the organisms identified from the stomach is the one which causing the pneumonia in the lung. Even the organisms identified in the upper respiratory tract, we cannot say that is the organism causing the pneumonia in the lower airway or the lung, because there are a lot of commensals. Even the Streptococcus pneumonia is a commensal. So don't do gastric aspirate for the diagnosis of bacterial pneumonia. It's mainly to diagnose TB, because Mycobacterium TB is not a commensal. If we identify this Mycobacterium TB in the stomach, obviously that has come from the lower airway or from the lungs, or there is the one causing the problem, but it is not vice versa with the other bacterial infections. So the BAL is the gold standard at the moment, as we don't do biopsies, the bronchial lavage, and sometimes we can use pleural point or other respiratory samples. Antigens, only discuss serology. Sometimes we can, like this COVID, we use the rapid antigen test or PCR test. Okay, so the management, I don't want to go into details because it's the complicated thing, the management of pneumonia. But one of the most important thing in the management is the supportive care. Usually we focus about the antibiotics, but not only the antibiotics, it's management of fever, antipyretics, because child might be in distress, hydration and electrolytes. Monitoring is one of the most important things. So the trends of these figures are the most important things. So signs of deterioration, early intervention if the child is deteriorating, the child is showing features of hypoxia or hypocarbia or the respiratory failure. So monitoring is very, very important, because the main reason for cardiac arrest in children is hypoxia. It secondary to respiratory diseases, not the primary heart diseases like in adults. So we have to supply oxygen, or sometimes we might have to provide some respiratory support if the oxygen supply or the oxygenation is not sufficient, or the respiratory system is in a failure to provide its necessary function. So high flow, heated, humidified high flow nasal cannula therapy is a very common, very popular thing which we are using. It's not an ICU procedure. Now it's a ward procedure. CPAP, or final thing is invasive ventilation. And the antimicrobial. So antibiotic selection of children with pneumonia. As I mentioned earlier, the upper respiratory tract infections majority are due to viruses, and usually antibiotics are not indicated. But even though I said maybe 70% of the time the viruses would be there, still it's very, very difficult to differentiate viral from bacteria. So because of that, even all the majority of the guidelines worldwide, if we identify or diagnose pneumonia in children, if it fulfills the criteria clinically or radiologically, we have to start antibiotics, even though it's a possible viral infections. So it's very important because we cannot differentiate viruses from bacterial infections, pneumonia, especially in the lower respiratory tract. So because of that, if it is pneumonia, if you are certain about the diagnosis, need antibiotics for almost all cases. So what is the choice of antibiotics? Various remedies are there because of this resistant patterns, overusing of antibiotics. So various guidelines are there, but still the worldwide uncomplicated pneumonia, the drug of choice is amoxicillin, 40 to 50 milligram kilogram a day in 3 divided doses. So we may use higher doses in 2 divided doses, but practically still we are in our setup also, we may go for chlormexiclav, trimexiclav, or some other even like this macrolides if we are suspecting mycoplasma chlamydia infection. If the child is having severe disease, we can consider IV antibiotics, especially if they are unable to take orally, or the oral antibiotics are not tolerating, or severe complicated pneumonia or septicemia. Obviously, we have to use IV antibiotics, chlormexiclav, cefuroxime, cefotaxime, or ceftriaxones. So again, same thing. We have to keep these antibiotics reserved for the actual diagnosis of pneumonia. If it's just a upper respiratory thing, or just suspicion of pneumonia, it's better, because now we are facing the problem of overusing or misusing these antibiotics. At the moment, the cefotaxime is not available, most probably throughout the country, like that. So this is important point. We have to review our antimicrobial practices or use of antibiotics, rational use. This is actually the very high time. I just want to stress that as well. So uncomplicated pneumonia, the duration of treatments, there are some studies whether it's 3 to 5 days or enough, or 5 to 7 days. Yes, some of these studies shown it's equally effective, even though we give 3 to 5 days. But now current recommendations, they're better to give it for sufficient durations, because sometimes it might end up with complications. But if it's already complicated pneumonia, like pleural effusion or empyema or necrotizing pneumonia, for abscess formations, we might need a prolonged course of antibiotics. Chest physiotherapy, this is another thing used in most of the time in private sector, but still there's no place of chest physiotherapy in acute stages. Sometimes children with chronic lung diseases, when they come in with an exacerbation, there's a place, obviously place for airway clearances, but otherwise we should not give chest physio to all children with pneumonia, because these changes or the immune system, especially the macrophages, they are scavengers, are capable of removing these exudative particles and clear the inflammation or the materials filled within the alveoli in children with pneumonia. And then the complications, if the fever is persisting, lung signs are persisting, child remains ill, so then we have to consider possible of development of complications. The commonest thing is a parapneumonic effusion, or maybe necrotizing pneumonia, or even we can see some children developing lung abscess formation following pneumonia. So I am not going to details about the management. This is a Sri Lankan SLCP guideline. The nice algorithm is given. How do we tackle in a child with parapneumonic effusions? sometimes later might need surgical interventions as well. So, what are the complications? So the usually ones, even though they develop complications in normal children with normal immunity, no major long-term effects of uncomplicated pneumonia, even with complicated pneumonia. But sometimes, if this damage is significant, sometimes they might have long-term complications of persistent restrictive or obstructive lung diseases, and sometimes might related to the development of bronchiectasis or COPD in adult patients. Problems or the severe infections or severe respiratory infections, especially uncomplicated pneumonia, developing in the small age or as children. Again, summary, same thing. So management of children with community the acute respiratory infections. So it's very important to identify pneumonia, rational use of antibiotics, and rational identification of children who do not require antibiotics, and use of other measures like bronchodilator and other measures to the management of these children. So rational approach is very important, not to misuse antibiotics, but same times give antibiotics in appropriate way in appropriate patients. Thank you.
We are in a little bit of short of time. We will leave the questions to the end. Right. So, thank you for inviting for this lecture today. So today I'm going to discuss something away from the straightforward clinical practice, but it is really important in our clinical practice as well in the day-to-day. So, so far you have been listening to all the clinical features of pneumonia, especially a respiratory tract infection among children, and how it is being diagnosed and how it is being managed. So why do we worry too much about this respiratory infection among children? So as we heard from the very first lecture and from the subsequent presenters, so this is one of the major killer of children. So it is really important to identify early, as Dr. Chandra mentioned, diagnose and promptly treat them to prevent morbidity and mortality among them. So if you look at the global trend first, so you can see in the early 90s, the global under 5 mortality has been about 93 deaths per 1,000 live births among the under 5 children. And it is been declining over the time up to 2020. Now it is 37 deaths per 1,000 live births. And but though the global value being identified as 37, if you look at the regional variation among the death rate, so the Africa being the top as usual, but you can see still the Southeast Asia is in the 3rd place. So it is really important that we need to address this value and prevent, safeguard our children from this immediate killers. And if you look at the global trend for the mortality data in the respiratory tract due to the respiratory tract infection, again, you can still see that it is been declining over the time. So it is being in 2000, not verified, it is being nearly 18 deaths, but now it has dropped to 8, but still there are high number of children are dying because of the respiratory tract infections. So though it is now in recent data, though it is being coming down in the number, and still there is regional variation in the distribution of this hotspot. So initially it was mainly around the Asia and sub-Saharan area. Now it is now moving to the mainly to the Africa and the sub-Saharan. But though it is being moving, still we are at risk in the South Asian region. So that's why we need to promptly act about this issue. So this is the latest data I could find from the Sri Lankan context. So this study was done in the Jaffna University unit. And they found they were collecting data about the patients who are presenting with respiratory disease to the Jaffna Teaching Hospital. And out of 4,127 total admissions to the pediatric wards, 31% of the admissions were due to the respiratory illness. And if you look at the infectious disease burden, it's still talking. It's 92%. And you can see they have been in the hospital nearly more than 4 days. So that shows the cost of the disease burden to the system as well as to the community. So that's why we are really worried about this respiratory tract infections among children. So there are a couple of challenges that we see when we diagnose, treat, and manage respiratory infections in children. First is the clinical presentation. As Dr. Ruanti and Dr. Channa mentioned, so these are more or less very non-specific symptoms. We know from the common cold to the complicated pneumonia, children would present just with fever, cough, maybe wheeze. So it is quite non-specific, but there should be some other clinical signs, as Dr. Ruanti mentioned and showed us, that we need to concentrate on those features. So identifying key clinical features and sinister signs are far more important to overcome the challenge of identifying the clinical status of the patient on admission. And also about the diagnostic test. So as Dr. Shirani mentioned, so we are not in sort of a high privileged area to do all the diagnostic tests. So we have to rely on certain limited amount of diagnostic tests. So in that case, again, you have to go back to your clinicals and to see clinically whether the child needs treatment, whether the child needs admission, and how soon, how urgently you need to attend to the patient. And again, about the management options. So we do have antibiotics, but very limited. We know with the current situation, we are taxing quite a lot of money on the limited amount of antibiotics. And if you think of the etiological agents, we know the viral infections are the most common cause for the upper respiratory infection in children. But we have very limited, not only we, but globally very limited antiviral agents are available. So we have to know in which occasions that we need to use them, and we have to use them rationally. So it is challenging when you work in a clinical setup, whether you could overcome all these challenges. So as I mentioned, so the respiratory system, it is starting from nose to the pleural space, and all these features are, clinical features are similar to all the presentation. So what are the suggestions that we could tell you that to improve the outcomes of these patients who are coming to the clinical setup without using much of the resources that we have? So as Dr. Ruanti and Dr. Channa was highlighting, so always we have to look for the sinister symptoms, especially concentrate on the work of breath, the tachypnea. So that is the simplest thing that we can do in our examination, even without touching the patient. So you can observe and see what is the patient's work of breathing and how distressed they are. So that is one of the key clinical signs that you can use to classify their respiratory distress. And at the same time, we have to see whether there's any inappropriate drowsiness, agitation, bradycardia is there, because when they are initially when they are hypoxic, they try to compensate. So they try to breathe fast, and your heart is pumping very fast to send all oxygenated blood around the body, especially to the brain and the heart. So in that case, if you see the child is bradycardic, so that is the sign of hypoxia. So knowing these key clinical features to prioritize the patient's management is really important. So we need to implement and then we need to, maybe we can make posters and highlight on our clinical areas about the sinister symptoms and the key clinical presentations. And also we need to remember that we need to prioritize some patients, because all the children who are presenting to the outpatient or to the primary care would not healthy at all the time. So they might be carrying underlying diagnoses and they are at high risk of developing complications or severe disease, especially if they have born prematurely, if they are carrying syndromic diagnosis, especially trisomy 21, congenital heart disease, chronic lung diseases, neuromuscular diseases, and when they are very younger. So we have to be very cautious if you see this patient, even though the physical signs and symptoms doesn't look mild at the time of presentation, this patient should not leave the hospital without the reassurance that they are not progressing into the severe disease, because they can rapidly progress into the severe disease. So it is important to admit these patients or get the opinion from the pediatric team before they were sent home from the OPD basis. And these are some of the standard protocols that can be used in the outpatient or in the primary care level, where you can differentiate when a child comes with cough and fever. So it will show you basic physical clinical features to differentiate whether this looks like a mild pneumonia or mild respiratory infection, or it's in the degree of severity is moderate to severe. So these clinical features, stick to these protocols, would help us not to miss important patients. And again, the same as for the management options. So if the baby is having mild pneumonia, so they are, as Dr. Ruanti mentioned, that if they're well fed, their activity is normal, and the parents are reliable, then of course you can arrange home-based care. And always, it is necessary to always guide with appropriate antibiotic therapy only. It is not to like top up with antibiotic therapy when each time they come into the outpatient or to the primary care. So knowing these basic management steps would be important in managing patients in the primary care. And then use of antibiotics. So this is very important, as Dr. Channa mentioned. So use of antibiotic is really important in the management of pneumonia, but we have to keep in mind, when you use the antibiotic, it has to be a rational use of antibiotic, because now with the current economic crisis, we are lack of a lot of antibiotics in our hands. So in that case, it is really important to think of what is the commonest organism that could cause this condition to the baby based on their age category, based on their underlying disease condition. And based on that, you can use, even we have standard protocols from the Microbiology College and from the College of Pediatricians. There are standard guidelines given and about the antibiotics. So we can follow those guidelines to minimize antibiotic usage. And also it is really important in the upper respiratory infection not to use too much antibiotic each time. When the patient's coming to the ward, we can see, so they have been having a couple of antibiotics at least for minimum 3 or 4 days. And then when they come to the ward, that actually we are run out of antibiotics to be used, and we are in a mind that what to be used in the next point. So it is really important to safeguard the little amount of antibiotic options that we have for the complicated patients. And then again, the surveillance is really important in two main aspects. One aspect is surveillance of the microbiological organisms. Especially within the institutions, we should know what are the commonest organisms that we are dealing at that time. So as Dr. Samanmali mentioned at the beginning, so they have done a small surveillance in their ward and found to have now the influenza virus has been coming up. So knowing that fact is really important when you are managing the patient. And at the same time, their antibiotic sensitivity would be different. So locally arranging surveillance, how much we are using antibiotics. So what is the commonest antibiotic we use in our first contact basis? So those are really important to know what are the best clinical options that could be used in next couple of weeks. And then so there are a couple of experience coming from the other countries that we can use and replicate, where they use the clinical care pathways in managing respiratory tract infections, especially from the outpatient department onwards. So they have given clear-cut clinical features and signs and when to use the antibiotics. So following these guidelines would help us to improve our quality of care giving to the patient, as well as cut down unnecessary costing to the healthcare sector. And this is one other guidance or the algorithm for the primary care first contact medical officers. So these can be pasted in the outpatient department, maybe in your GP practice. So that gives you always visual contact with all these algorithms, and always you would start thinking whether do I have to admit this patient, do I have to give antibiotic to the patient? And then using this traffic light method, that is one of the famous way of like categorizing patients. So if it is green, they are safe. If it is yellow, then you have to be vigilant about the patient. And if it is red zone, then you have to act urgently. So likewise, we can categorizing and prioritizing our services to the patient. Not just the doctors, addressing the doctors would sort out this problem. So we need to address both the parents as well. So these are a couple of standard information given to the parents, because so as Dr. Chandna mentioned, so there now, of course, the parents would come again and again because child is having persistent cough. So giving some fact sheets and maybe home remedies options, so that will help them to reduce coming into the healthcare facility and cut down the burden to the healthcare facility. Right. Okay. So thank you so much. So it is not a sort of a direct clinical input I wanted to share. It is what are the options that we can use to prevent complications among the children, as well as cost to the healthcare sector. Thank you. Thank you very much for joining with us with the Clinical Society of Teaching Hospital, Colombo South Teaching Hospital. And it is really nice when we have a good audience because we need to disseminate this knowledge among you all to improve the quality of care that we provide to our little patients. Thank you so much for coming, joining, and joining online. Thank you very much for all the resource personnel who join us today, irrespective of their busy schedules. Thank you.